So, about the congenital cyanotic heart disease, why it is called congenital, I don't talk it. Why it is called congenital? Because it is present since birth. Actually, it is from since birth or before birth? Before birth. So, that's why it is called congenital disease. And as it is concerned with the heart, so it is congenital heart disease. And its presentation is usually there is cyanosis at presentation. Cyanosis. This means bluish discoloration of the skin and is bluish discoloration of the skin and mucous membrane is cyanosis. Bluish discoloration of the skin and mucous membrane is cyanosis. So, the total problem is congenital cyanotic heart disease. And you know about the heart diseases, that there are a large number of heart diseases that are going on. And of these, a substantial portion is cyanotic congenital heart disease. Now, when there is cyanosis, we know that the we know there are two types of actually there are three types of congenital heart diseases. One is without cyanosis, acyanotic heart disease. Acyanotic heart disease is again divided into two groups. One is left to right side, another is obstructive heart disease. Aortic stenosis, pulmonary stenosis, or coarctation of the aorta. Obstructive heart disease is not in the course. So, acyanotic heart disease is discussed before in the first day, and today we will discuss about the cyanotic heart disease. But there is cyanosis, it means these children will produce bluish discoloration of the skin and mucous membrane. Okay. Now, why there is cyanosis? We know that there are two chambers of the heart. Left side gives the oxygenated blood to the system, and right side gives the deoxygenated blood to the lungs for purification. It means for oxygenation. That returns against to the left side. So, if there is any mixing of the right side blood, impure blood to pure blood, there is cyanosis. In these conditions, the conditions where it is there, in these conditions of cyanotic congenital heart disease, the right-sided blood is mixing with the left-sided blood. That's why it is also called the right-to-left shunt disease. Right-to-left shunt disease. The prototype of this disease, most important, it means most important of this disease is Tetralogy of Fallot. Dr. Fallot in 1888 first published 10 cases of this cyanotic heart disease in the German Cardiology Journal, and from that time, this is called a Tetralogy of this disease of Tetralogy of Fallot. The most common cyanotic heart disease after the infancy, or preferably after the age of 6 months, is congenital cyanotic heart disease. Most common is Tetralogy of Fallot. So, a child is coming at the age of 5 years with cyanotic heart disease, your first diagnosis should be Tetralogy of Fallot. A child presenting at the age of 2 years with cyanotic heart disease, diagnosis first is Tetralogy of Fallot, unless proved otherwise. We will have to investigate and find what other conditions may be there. This is important thing. Okay. Now, let us go to what is happening in Tetralogy of Fallot. These are the examples of the other cyanotic heart disease. These are called the 5T disease. These are mentioned everywhere as cyanotic heart diseases. Of these, the first one you see the Tetralogy of Fallot. The second one is transposition of the great arteries. It means there are two great arteries at present. Two great arteries are there. One is aorta and another is pulmonary artery. Aorta arises from the left ventricle and pulmonary artery arises from the right ventricle. So, if any conditions, the aorta arises from the right ventricle and pulmonary artery arises from the left ventricle, that condition is called transposition of the great arteries. Okay. Similarly, another thing is tricuspid atresia, where the tricuspid valve is atretic. That is, it is not functioning normally. The valve is atretic. Okay, and that is called tricuspid atresia. In that condition, there will also be cyanosis. You will see the picture, and then you can feel how there is right to left sound in these conditions. And total anomalous pulmonary venous return, TAPVR, total anomalous pulmonary venous return, another example of cyanotic heart disease, where all the pulmonary veins are draining in the right atrium or superior vena cava or inferior vena cava, whatever it may be. So all the pulmonary veins are draining. Normally the pulmonary veins drain in left atrium. It's pure blood draining in the left atrium. But in this condition of total anomalous pulmonary venous return, all the pulmonary venous blood are draining in either superior vena cava or the right atrium or the inferior vena cava, whatever it may be. The result is that the left atrium is not getting the pure blood, it is the impure blood. Okay, so last one is Truncus Arteriosus, the main trunk which divides by the spiral septum into aorta and the pulmonary artery. That septum is absent. That is called Truncus Arteriosus. During the development of the heart, the main trunk which arises from the ventricles is divided into two by spiral septum. That spiral septum is attached with the infundibular part of the ventricular septum. If that septum is not present in the initial part, so that is called Truncus Arteriosus. So here the both oxygenated and deoxygenated blood is going to the main trunk, and then they divide the blood into aorta and pulmonary artery. Let us go to see the picture what is actually happening. This is Tetralogy of Fallot, and if you look at the picture carefully, you will see that in Tetralogy of Fallot, the thing is that you look at the picture, there is a large VSD, and that VSD is non-destructive VSD. It means this VSD is large one. There is easy passage of the blood. Next you go to see the pictures. This is aorta. The aorta is overriding the right ventricle. The aorta is coming towards the right ventricle. As a result, the pulmonary artery is narrow. Aorta is overriding. Aorta diameter is larger than the pulmonary diameter, and the aorta is overriding the right ventricle. This portion is overriding the right ventricle. And there is pulmonary stenosis. The artery is narrowing. And there is right ventricle is thickened. This is right ventricle wall is thickened. So there are four components of Tetralogy of Fallot. What are the four components? There will be, if you look at the picture, you will see that's just justified. Tetralogy means four. So what are the four components of the Tetralogy of Fallot? This is one important question which may be asked in the Viva or other areas. What are the four components? Component one is large non-destructive VSD. Component 2 is overriding of the aorta. Component 3 is pulmonary stenosis. And component 4 is right ventricular hypertrophy. Okay?
Right ventricular hypertrophy is ওইটা ক্লিয়ার হচ্ছে কেন ওয়ালটা ঠিক হয়
ওয়ালটা একটু রাইট ভেন্ট্রিকুলার কেন হচ্ছে আমি বলছি এই ভালো করে শুনবে গল্প করো না তোমাদের দুজনকে বলছি তোমাকে আর রেখে গল্প যদি করতে হয় বাইরে যেয়ে করো না বেরিয়ে যাও ক্লাস থেকে বেরিয়ে যেয়ে করো ক্যান্টিনে বসে বসে গল্প করো 5টা লোক ছেলেকে ডিস্টার্ব করছে কেন বাপের পয়সাগুলো নষ্ট করে হ্যাঁ So now why there is right ventricular hypertrophy? Because right ventricle is to push the blood to the pulmonary artery. As there is pulmonary stenosis. The question is right ventricle has two options. Right ventricle has two options. If you follow the case, option 1, right ventricle can push the blood to the pulmonary artery. Option 2, right ventricle blood may pass to the aorta. But remember, in nature, everyone will like to pass through the natural pathway. What is the natural pathway of right ventricle? It is the pulmonary artery. So as it is tenos, so right ventricle try to pass the blood through the pulmonary artery. Okay, but there is stenosis, so right ventricle is to work more. That's why there is right ventricular hypertrophy. Okay, so these are the four components of the tetralogy of Fallot. Go to the other areas, transposition of the great arteries. Here, if you look the picture carefully, you will see that this is the aorta, and aorta takes origin from the right ventricle, and this is the pulmonary artery, takes origin from the left ventricle. So what is happening here? There is a reverse position of the aorta and the pulmonary artery, and there will definitely be cyanosis. If you go to the next component, the total anomalous pulmonary venous connection, and you go to the pulmonary veins. So here is the pulmonary veins. These are the pulmonary veins. Okay, these are the pulmonary veins. These pulmonary veins, normally they should drain into the left atrium, but here they are draining into the superior vena cava, then coming to the right atrium. So where from the left atrium is getting the blood? It is through a large foramen here, that is called atrial septal defect, through which the left atrium is getting blood from the right atrium. Okay, so this is called total anomalous pulmonary venous connection. Here also you will get the cyanosis. Next important thing is the Tricuspid Atresia. You know this valve is known as the mitral valve. Mitral valve, left atrium to left ventricular valve, and this valve is the normally actually tricuspid valve. But here the valve is not open. Here the valve is open, but here there is no valve is not open. It is atretic valve. Atresia is there. Because of the tricuspid atresia, right ventricle will not get blood from the right atrium. So where from the right ventricle will get the blood? There must be some VSD. There must be some VSD to supply the blood to the right ventricle. A right ventricle naturally is not functioning properly. It is atretic. Only a small portion of the right ventricle will function. Okay. So next to the Truncus Arteriosus, we have discussed. These trunks would be divided into aorta and the pulmonary artery, but here there is no division. Here the main blood from the both left and right ventricle going to the truncus, and then the blood is passing to the aorta and the pulmonary artery. Okay, so there must be a large VSD for mixing of the blood. This is the. These 5T are common cyanotic, congenital cyanotic heart disease, of which 5T means the constructive volume, and of which the most important is the tetralogy of Fallot. Now, I think I should not discuss the embryology of tetralogy of Fallot. Actually, what is happening is just ectolinability. What is happening in tetralogy of Fallot, you should know how the ventricular septum is developed. Ventricular septum is developed from the three important sources. Source 1, there must be a muscular part of the ventricular septum. Source 2, infundibular part of the ventricular septum. There is the continuation of the spiral part. And source 3 is the proliferation of the atrioventricular cushion. So, part 1, membranous part, is the muscular part from the lower part, is the infundibular from the upper part, and middle part is from the membranes. Now, suppose the infundibular part is not attaching to the membranous part. If it is the membranous part, say, infundibular part is here, but it is not attaching to the membranous part, it is shifting to the right. What will happen? Because of the shifting of the infundibular part or malalignment of the infundibular part of the ventricular septum, it is shifting to the right, so there will be a large VSD like this, and there will be small pulmonary artery, there will be large aorta, and aorta will override the right ventricle. So this is the background which is described by Fallot as a mechanism of this tetralogy of Fallot. So what is the most important background? Is the malalignment of the infundibular part of the ventricular septum. বোঝা গেছে না বোঝা যায়নি? উঠে এসো, উঠে এসো তাড়াতাড়ি, সময় নষ্ট করুন, উঠে এসো, এখানে দাঁড়াও, ঠিক আছে? ভালো করে সবাই look at this pictures. Just imagine, this is the muscular part of the ventricular septum. This is the infundibular part of the ventricular septum. This is the membranous part of the ventricular septum. Here is the right ventricle, here is the left ventricle. Is it clear? Now this infundibular part, here from the aorta is arising, aorta. Here from the aorta is arising, here the pulmonary artery is arising. Now this infundibular part is malaligned and here is coming like this. So the aorta is dilated, the pulmonary artery is very much tenosed, and there is large ventricular septum defect. And because of the stenosis of the pulmonary artery, the right ventricle is hypertrophic. Ja. So this is about the development of the Tetralogy of Fallot. Main root is the malalignment of the ventricular septum. And it is easy then to explain the cyanosis in these conditions. Let us go again to the Tetralogy of Fallot cases. Now, so degree of cyanosis, where it is, who will dictate the cyanosis will occur or not in case of Tetralogy of Fallot? Who will dictate? The amount of blood flow to the aorta. Amount of blood flow to the aorta. This amount of blood from the right ventricle flow to the aorta will dictate cyanosis will be present or not. If the reduced hemoglobin is more than 5 gram percentage, there will be cyanosis. If there is large amount of blood, impure blood, goes from right ventricle to the aorta, then cyanosis will be much more. If there is very small amount of impure blood is going from our right ventricle to the aorta, then cyanosis will be less. So suppose a child is having small amount of blood from the right ventricle is going to the aorta, then there will be no cyanosis. You cannot detect cyanosis in this side, and you will not get cyanosis. The child looks pink, no cyanosis. This is known as pink Fallot. So what is pink Fallot? That is the degree of pulmonary stenosis is not sufficient, it's such that the amount of blood which is going to the aorta from the right ventricle to the aorta is not very large. That is why there is no cyanosis, and till the child is suffering from the Tetralogy of Fallot, there is no cyanosis. This is called pink Fallot. That is also the reason why you will not get cyanosis since birth in a case of Tetralogy of Fallot. The reason is why at birth usually you see the degree of pulmonary stenosis is not critical enough at birth. With increasing age, suppose at the age of 4 months to 6 months, there will be cyanosis. The question is why then at the age of 4 or 6 months, the baby will get cyanosis? Why not from the very beginning, the baby will get cyanosis? It has been found that the degree of pulmonary stenosis increases with increasing days of the child. And why? Because here is the space where there is large number of the beta 2 receptors. Beta 2 receptors. During stress and strain, where there is large number of beta 2 receptors placed, catecholamines when secreted to a great extent, that part gets constricted and hypertrophic. So with increasing age, it is not present since birth. With increasing age, it will get stenosed and there will be cyanosis. That's why we will get cyanosis from the age of 4 and 6 months. There may be cyanosis at birth. Suppose there is a conditions where since birth, this part, suppose in the conditions since birth, this valve is very, very stenosed. So much stenosed that very little amount of blood is going to the pulmonary artery. Will the cyanosis at birth or not? Definitely cyanosis will be at birth. So tetralogy of Fallot with critical pulmonary stenosis. Tetralogy of Fallot with critical pulmonary stenosis will present with cyanosis at birth. Or suppose this part is atretic. There is no way to pass blood through this. So tetralogy of Fallot with pulmonary atresia, atretic part. No blood is going to there. That may present with the cyanosis at birth. So don't think that in always it is the rule that tetralogy of Fallot will not present cyanosis at birth. It may be, but that depends on the degree of pulmonary stenosis. So who will dictate? Who will dictate that whether cyanosis will be present or not? Who will dictate? It is the degree of pulmonary stenosis. It is the degree of pulmonary stenosis that dictate whether the baby will get cyanosis or not. Whatever it may be, as the blood is going from the right ventricle to the aorta, there is cyanosis. Whenever the cyanosis is there, the oxygen level, deoxygenated blood in the deoxygenated hemoglobin level in the blood is increased. If oxygen deficiency is there, then what will be the effect of that on the Krebs cycle? বলো তাড়াতাড়ি 1 সেকেন্ড সময় বসে বসে 1 সেকেন্ড হ্যাঁ কি Krebs cycle ভালোভাবে হবে না So very good. It's a very good student of biochemistry. So if the oxygen is not there, the Krebs cycle will suffer. So how the body will get energy? By glycolytic pathway. Without going the substrate to the Krebs cycle, they will follow the M-name Meyerhoff glycolytic pathway. That is, they will produce the lactic acid and only 2 molecules of ATP. Instead of 38 molecules of ATP by Krebs cycle, the glucose will produce only 2 molecules of ATP. So what will happen? Large amount of glucose will break and to produce the small amount of ATP and huge amount of lactic acid. And as the lactic acid will produce the acidosis, so metabolic acidosis is common in the case of tetralogy of Fallot or cyanotic heart disease. Is it clear to you? So one of the complications of this tetralogy of Fallot is that there will be metabolic acidosis because the cyanotic blood is going on. As the cyanotic blood is going on, there will be metabolic acidosis, and that is always the child is in hypoxic state. So what will be the effect of that? There is release of erythropoietin from kidney. A large amount of RBC will be formed. So there will be polycythemia. But if you examine the hemoglobin level of that patient, you will get the hemoglobin level is good. But the patient is suffering from anemia. Reason is that large amount of RBC which are formed in this tetralogy of Fallot, FDRBC does not contain sufficient amount of hemoglobin. So those RBC looks at microcytic, hypochromic structures. But there is polycythemia. So normal actually the PCB range which should be kept in tetralogy of Fallot below 60, that will be say 65, 70, sometimes 80 maybe percentage of plaque cell volume may be there, which is normally should be in cyanotic heart disease less than 60, normally should be kept. Actual normal value in normal person without cyanosis 45 to 50. Okay. So in case of cyanotic heart disease that is increased, but you should not give chance to increase more than 60. But here some cases will get the polycythemia is severe enough or critical enough. And if there is polycythemia, what will happen? They will cause the flow of blood, sluggish, small vessels where the blood is going, polycythemia causes less insufficient blood supply. And that can give rise to lack of blood supply to the important structures like the brain. উল্টোপাল্টা বলো না বাবা, না জেনে বলো না, তুমি চুপচাপ বসো, না জেনে কোনো কথা বলো না, এত সোজা নয় জিনিসটা। So a large amount of blood is going to the which is supplying the large amount of blood to the brain. There is polycythemia, dragging the vessels to there because of the large amount of RBC, and the child may present with the hemiplegia also. Hemiplegia may be manifested. Okay, so as there is a mixing of the blood from the right side to the left, right side to the aorta, and you know the lung has a tremendous function for purification of the blood. There are a large number of macrophages, they are present in the lungs, which engulf the small embolas and small bacteria, infective organisms, etc. Suppose there are, say, 10 bacteria is present here, they are, without passing through the pulmonary artery, they are going to the aorta. They are going to the, as there is a direct communication, it's a brachiocephalic trend, so they are going directly to the brain. These bacteria in the brain can give rise to infection in the brain called brain abscess. So brain abscess may be one of the complications of this, or one of the matter related to the tetralogy of Fallot, just like hemiplegia. But brain abscess will occur in those conditions where there are chances of flow of the bacteria in the heart. Suppose the child is having some, say, trauma, some ulcer, impetigo, etc., which is usually above the age of 2 years when the child is free. Below the age of 2 years or 1 year, the mother is very much cautious about his or her child. Mother will keep the child in, say, under her control. That's why you will get the hemiplegia is more common below the age of 2 years, whereas the brain abscess and other things are common above the age of 2 years. Now let us consider other conditions of this tetralogy of Fallot. As the cyanotic blood is going to the brain and cyanotic blood is going to the every structures, so what is the expectation in relation to growth and development? Tomorrow, growth and development ki hobe?
Stunted.
Very good. Stunted, delayed both. So growth and development will be delayed. Growth and development will be delayed in cyanotic heart disease. We are discussing tetralogy of Fallot. Growth and development will be delayed. And as there is cyanosis, you will get definitely clinically cyanosis will be there. And that is the clinical methods you know how to look at the cyanosis. As the cyanosis is present for the long time, you will get the clubbing also be there. Right? So cyanosis, clubbing, delay growth and development, these are very common in tetralogy of Fallot. The question is, now let us consider the things. Suppose a child is at 2 years and child is playing, moving here and there and running, child is running. What will happen during running? তুমি একটা বলো, ছুটলে কি হয়? হার্ট রেট বাড়ে না কমে? বসে বসে বলো, কমবে? কেন বাড়বে? ক্যাটেগোলামিন বের হয়, তাই না? সিনথেটিক হরমোন ক্যাটেগোলামিন বাড়ে। So during playing, well, 2 years child, say 1 year child or 1.5 years child is running and playing, and during that is increased release of catecholamines. ঠিক আছে? And also heart rate keeps very low, so there is more and more circulation. Now let us consider the conditions. Here the child is, this child is running, and age of the child say 1.5 years. Child is running. So more and more heart will pump more and more blood, heart rate is increased. So more and more blood that will also pass into the aorta, impure blood. So and this aorta will give rise to impure blood is going to the respiratory center, the heart center. There will be more and more increased respiration rate, more and more increase of the heart rate, right? And more and more respiratory rate and more heart rate, that can give us to more and more blood to the aorta. So there will be increased cyanosis. Another thing that during running there is increased secretion of catecholamines, and I have told you that catecholamines are more present in this part. So if there is a more amount of catecholamines is there will more contraction of this part of the pulmonary artery. Okay, so there will be less flow to the pulmonary artery. So if the pulmonary artery flow is restricted, where the right ventricular blood will go? Through the aorta. So there will be more cyanosis. These are the conditions. That is why during exercise and other conditions, playing, crying, exercise, and other conditions, the child will be becoming more and more cyanosed, and that is known as cyanotic spell or hypercyanotic spell. Oto, tumi. Bolo, Oto. If a child aged 1.5 years is running, playing football, the child is suffering from Tetralogy of Fallot, what will happen? What is the condition of that problem? কি হবে বাচ্চা হ্যাঁ তাকে কি বলা হয়? What is that name of that? So cyanotic spell, you have got the explanation why the cyanotic spell. Usually it occurs below the age of say 1 year is maximum, below the age of 2 years cyanotic spell may occur. After the age of 2 years cyanotic spell may occur, but the incidence is less because child knows how to manage it. Now let us consider how the flow of the blood to the aorta can be restricted. If I restrict, say suppose a child is doing some exercise and child is trying to restrict the flow of the blood to the aorta. এইখান দিয়ে ব্লাডটা বেশি করে যেতে দেবো না আমি, এই দিকে ব্লাড বেশি করে আসতে দেবো না। If I like to restrict the flow of blood in the aorta, then what I have to do? I have to increase the resistance of flow. I have to increase the resistance of the flow. Is it true? How you can increase the resistance of the flow? Suppose my arm is getting blood supply like this, and I like to resist to some extent the blood flow, resistance in this vessels. And what I have to do? I have to flex this. Okay. If I flex this, then brachial artery is partially constricted, and there will be increased resistance of the artery in the proximal part. So similarly, in this case also, if you তুই আজকে মডেল হয়ে যাও আমাদের বস নট এইখানে উঠলাম তো যা বলবো কর জীবনে ভুলবি না বসে পড় বস একদম বসে এই পুরোটা বসে ওই ওই রকম না এই এতটা পাটা ওরকম করা স্কোয়াটিং পাটা রাখবে যেমন গেছি পাটা তোল এখানে রাখ পা দুটো হ্যাঁ এরকম বস Now if this is the position, this position is known as squatting position. Now what is happening here? Look at this. What is happening here? There is constriction. There is constriction of this artery, complexities artery. At the same time, there is pressure in the calf muscles. So peripheral return, calf muscles ka ki bola hai? Peripheral heart. So peripheral return of the blood from the periphery is restricted by the pressure. This is number one. Number two, there is folding causes increased resistance. Resistance to the arterial blood. কোথায় কোথায় folding হয়েছে? Complexities artery তে folding হয়েছে, femoral artery তে folding হয়েছে, তাই তো? And also posterior tibial artery খানটা folding হবে, arterial dorsalis pedis folding হবে. So these causes to some extent resistance of the flow to the aorta. This position is known as squatting position, and that can give rise to less amount of blood flow to the aorta, and cyanotic spell is decreased. Okay, cyanotic spell is decreased. There are also other areas. Suppose the person not known about this, then what he can do? পাটা ক্রস করে দিকে এরকম করে ধরা। This is also another position. This is also another position where the femoral artery is clinching and pubic artery is sidely flexing. That can also give rise to some resistance. Similarly, to reduce the sympathetic event, if the person is lying down, শুয়ে পড়লো ওখানে, চুপচাপ শুয়ে পড়লো, তাহলে কি হয়? There will be less amount of sympathetic challenge to that. Or in বস, বসে পড়লো, চেয়ারে বস। If this is the condition, in that condition also you will get the complexities artery is raised. Or if the child is very small, then child is taken by the mother in the mother's lap. That will also give rise to increasing the resistance to the aorta. These are the five positions. These are the five positions known as Tusso's position. Sorry, Taussig's position. Taussig's position for relieving of the cyanotic spell by the patient. But the most important is the squatting position, which is usually adopted by the patient, and it is already written in your book everywhere, squatting position. Okay? But these are the other positions for PG entrance it may be needed. There are the other five positions where the tetralogy of Fallot can be, cyanotic spell may be relieved by this position. Okay? Now, suppose in spite of that, the spell is not relieved, then we will have to do some treatment. I am going to that একটা সাইড আর্টিকেল কি করতে হবে চলুন নাকি মনে হচ্ছে একটা সাইড is an article. So I think this side is already explained. I think there is nothing to do with this slide. And I have also this is the incidence of the total cardiology cases. These are theoretical, not needed. Clinical features: cyanosis, carving test spell, squatting behavior, failure to thrive, all explained. Murmur is a clinical part that will be discussed later in the clinics. Then, next, diagnosis involves definitely all cardiac cases you should do diagnosis by as is clinical pictures plus X-ray, ECG, and echo, and sometimes prior to operation there is some CT, MRI. And hyperoxia testing is not required for you. It is on the newborn patient where there is any doubt. Suppose you are says respective distress is there, and you are thinking whether this distress is due to either cardiac defect or due to say lungs defect. In case of lungs defect, if you give oxygen to the child, 100% oxygen to the child, say 10 minutes 100% oxygen you are giving to the child, you will get the PaO2 of the baby is increased more than 250 units of mercury. Okay, but in case of cyanotic heart disease, it will never rise to that level. It is hardly 150 to 200. It never above 200 millimeter. That's called hyperoxia test. That is not important to you. It is a new oral theory you read it, and this is also not important. That is also discussed, embryology, that is discussed. That you know about the tetralogy of Fallot, but you must remember these four things, tetralogy of Fallot. After knowing so much thing of tetralogy of Fallot, if you fail to dictate the four components of the tetralogy of Fallot, is very bad. That should not be done. This is also discussed the physiology, how the blood is going to the body. I think it is also discussed. Chest X-ray, ECG, echo, I have told you. This is the X-ray chest. You see, there is as the lungs is not getting blood, lung is not getting blood properly, so you see that there is duct in the periphery. That is oligemia. Normal lungs, you know, there is it will come blood vessels marking should be up to the middle third, but here the blood vessels marking is not present in the middle third. In normal lungs, the vascular marking, which are present here, these are the vascular marking, that should be up to the middle. Is it clear to you? But here it is not coming in the middle for pulmonary oligemia, less blood. And pulmonary oligemia is present, the lung is not getting enough blood because of the pulmonary stenosis. And you see the right ventricular hypertrophy, you know, in tetralogy of Fallot, the right ventricular hypertrophy. So you see right ventricular hypertrophy, what causes? The left heart is pushed upwards, upwards and backwards, as you say, upturn effect. This is the apex. So apex is upturn. Apex is upturn. The pulmonary bay is empty, narrow pulmonary bay, apex upturn, and the pulmonary oligemia. This is the X-ray picture of the tetralogy of Fallot. I think this is also not very important for X-ray pattern. This is the echo people will say you there. You see the aorta overriding the left ventricle as well as Aorta is overriding the right ventricle, originating from the left ventricle, but here is also overriding. Okay, this is important, that is diagnosis of echocardiography. Differential diagnosis, the other causes of cyanotic heart disease. Now let us go to the how to treat this child. How to treat this child, and investigation you know, then last finishing is how to treat the child, because time is up. The last 5 minutes or 10 minutes I will have to keep for asking questions. Is it true? Should be or not, should not be? So let us go to the first slide again. তাহলে বুঝতে পারছো একটা সাইড ভালো করে বুঝলেই গোটা টেট্রালজি অফ ফ্যালট হয়ে যাবে। Now let us go to the how to manage this baby. I have told you that there is always deficiency of hemoglobin, say RBC ability. In a case of Tetralogy of Fallot, RBC numbers are there much more, but the hemoglobin percentage, though totally is high, but individual RBC is containing less amount of hemoglobin. If you do this blood test, now if I ask you how you detect the anemia in a case of Tetralogy of Fallot, if you answer, sir, I will do the hemoglobin percentage, I will say it is no, it is not the correct answer. Hemoglobin percentage may be normal in the case of Tetralogy of Fallot. What is happening that you should have to depend on blood picture, peripheral blood picture, RBC, microcytic hypochromic anemia, so that MCHC and say MCHC are reduced. Hemoglobin concentration in RBC are reduced, so we will have to increase the RBC. So you must give, for the treatment purposes, you should follow up the child and must give iron to every child of this cyanotic heart disease. Iron supplements should be given for every child with cyanotic heart disease. Okay, so this is very important. Iron supplements should be given as treatment. And second thing is that this is the pulmonary area which is narrow. I have told you there's excessive beta receptors are there. Beta 1 receptors are excessive. Excessive beta 1 receptors are there here at this place. You will have to prevent these receptors, because these receptors will cause contraction of the infundibular part of the pulmonary artery. So you will have to prevent those contraction. So beta blockers should be given. That's why propranolol is given in these cases. So iron and propranolol should be given in these cases. Okay. So this is another thing, is that whenever you get this type of child, you should find out see whether the growth and development, what is happening, and you should immediately refer to this child after giving the iron and propranolol to cardiac surgeon for definitive surgery. For definitive surgery, what they will do, they will close this BSD, and they will relieve the aorta, and they will remove the stenosis part of the pulmonary artery. Okay, so definitive surgery is the treatment of choice, and nowadays the technique is such that at the infancy also you can do the definite surgery. But if the growth is not very poor, if the growth is lacking, then you will have to increase the weight of the child and then do the surgery. But in case of critical conditions, when the surgery is not possible to do, but you have to do something, so naturally in that case, some measurement are taken, that is called temporary measurement. What is that measurement? And here this is a brachial artery, and this brachial artery, at the above it gives branches, 2 branches. One is right subclavian artery and right common carotid artery. The right subclavian artery, suppose here is the right subclavian artery. Now there is a shunt known as Goretak shunt, and by this shunt you can join the subclavian artery to the pulmonary artery. Subclavian artery to the pulmonary artery, one of the branch or main branch of the pulmonary artery. That is called subclavian pulmonary anastomosis or BT shunt, balloptosis shunt. Okay, you can do, if it is not possible to do the operation and the condition of the baby is deteriorating, in that condition you can do the BT shunt also. There are other shunts which are not very important. Sometimes some people say that the ascending aorta is connected with the pulmonary artery, or the descending aorta is connected to the pulmonary artery. These are not very important. Now, these are not done nowadays also, except in situation where the operation is not feasible. Next thing is that suppose a child at the age of 1.5 years is suffering from hypercyanotic spell during pain, then what will you do? First step is you will have to give rest to the child. Right? You will have to give rest to the child. I am showing you the side there. This is very important that you have to give the rest to the child. So this is rest to the child is very important. And the position, knee chest position. Knee chest position, it means that position which is shown. But it may not be possible always, but you take the child in the lap, mother's lap, so that there is restriction of the blood flow to the outer. And second important is increase the systemic vascular resistance. You have to increase oxygen, high flow oxygen should be given, and you know that oxygen also 100% oxygen can give rise to some pulmonary vasodilation and peripheral vasoconstriction also. So that can also help an oxygen. And child should be calm and quiet so that catecholamine secretion is decreased. And how do you give the calm and quiet child? By giving some sedation. Sedation by the morphine is recommended. If the morphine is not available, then other sedation may be given. Next, propranolol reduce the heart rate and also the right ventricular outlet obstruction. That is also relieved to some extent. You can give propranolol also in the IV mode, and you can increase the peripheral resistance by phenylephrine. Bicarbonate you can give because there is acidosis. You can reduce the acidosis by bicarbonate, sodium bicarbonate. And in refractory cases, we will have to, sometimes it is needed to give the mechanical ventilation or intubation. And in some cases, you should need the surgery, temporary shunting. Long-term management, you should maintain the beta blocker, you should continue, iron therapy should be continued, and definitely surgery is the treatment of choice. Okay. Now remember, in all these conditions, hydration should be maintained carefully. Hydration, so water. Because you know if the hydration there is dehydrated, the polycythemia will be increased. You have to make the hydration, IV fluid, other things. So this is important question for exam also. How do you manage the cyanotic spell? The most important management is to give the common question rest to the child, and popped up position, wash oxygenation, IV fluid, and bicarbonate solution for to treat the alkalosis, sedation by the morphine. Now somebody say ketotifen is sorry. কি বলে এখন দিচ্ছে যেটা কিটোপেন দিচ্ছে ভাস্কুলার রেজিস্ট্যান্স কমানোর জন্য. That is not recommended in standard textbook. But remember, the morphine is used for sedation, and you go to this propranolol IV and phenylephrine for increasing the peripheral vascular resistance. Okay, so these are the treatments which are usually given. And if it is not controlled, then we go the temporary shunt operation. Remember, if you do not give the adequate management in a case of hypercyanotic spell, the child may die. We have seen death of some child. Child brings late and then there is no way to save the child. You go, London? Death to দেখেছো অনেক না? Tetralogy of Fallot এসছে, death হয়ে গেল, ঠিক মতো সময় আসেনি, লেটে এসছে। Convulsion will death হয়ে যায়। Convulsion may occur because I told you the hypoxia is condition that can give a convulsion. Child may pass on to coma also. That is also one of the latest clinical pictures: convulsion, coma, and death. And these are critical conditions. So this is in a nutshell about the this is in a nutshell about the cyanotic congenital heart disease and Tetralogy of Fallot. So I should say you go and read your books, any of the book carefully, and Just remember these words. Hemiplegia, why a question খুব ভালো question. Why the hemiplegia is less than 2 years? Why the vein abscess after the age of 2 years? Let us consider 1-2 years baby is running. কি 2 বছরের বাচ্চা হতে পারে? তাদের দাঁতে কেরিস হয়, লজেন্সটাকে কেরিস হতে পারে, পেন্টাল ইনফেকশন হতে পারে। They can suffer from the trauma, repeated trauma. ট্রমার জন্য তার একটা ইয়ে হতে পারে, একটা আলসার হতে পারে। And there may be impetigo, অন্য বাচ্চাদের সাথে scabies, impetigo. So these infections are common in a 2 years old child, and that whenever there is infection anywhere, the blood will go to, the bacteria will go to the blood. It is called bacteremia. But if the bacteremia is there, now suppose some bacteria are going from there to here. What will happen? Those bacteria will pass. Normally the bacteria are present, but in normal situation the lung clears the bacteria by macrophages. But here there is no clearance. That may go to the brain and give rise to brain abscess. There will be other areas where the abscess may be there, other areas, but brain abscess is common. And it is usually the right side which is affected most, because the right brachial artery is directly communicated with the aorta. As there is a gauze defect here, two important things I should tell you, which I am missing. One thing is that heart failure is very common in Tetralogy of Fallot, heart failure. Except in few conditions, heart failure is not expected in case of Tetralogy of Fallot, because you see the heart is able to decompress easily. If there is any load in the right, say right ventricle, any load, that will pass out the blood to the aorta and the pulmonary artery. If there is any load in the left ventricle, it will pass out to the aorta. That's it. So heart failure is very rare in Tetralogy of Fallot, because heart is not suffering, load is not there. They can pass out the blood. But suppose the child is suffering or a person is suffering from severe systemic vascular resistance, severe systemic blood pressure, high blood pressure. In that case, systemic vascular, what will happen? Systemic hypertension, then failure. Similarly, suppose the infective endocarditis, because of the damage, because of this damage, any damage in the heart, bacteria is growing, there is chances of infective endocarditis. So if the infective endocarditis is there, that can give rise to heart failure by involving the myocardium, that is called myocarditis. In case of viral myocarditis also there are chances of heart failure, because heart will not pump. So these are the conditions where heart failure may be there. And infective endocarditis is also one of the important complications of this. And normally what is happening, there is operation, after operation, we are getting now cases of Tetralogy of Fallot after operation. And after operation, what is happening, there are chances of some leaking of the pulmonary artery, some leaking of the ventricular septal defect, sometimes arrhythmia may be presenting. We are getting this type of cases after operation. But the child is passing normal life. Aortic regurgitation is also one of the most common. Aortic regurgitation, most common post-operative complications. Aortic valve regurgitations. So we are not going in details. My next question is that why did it hemiplegia is common below the age of 2 years? Below the age of 2 years, child is very much protected by the parents. And there is less chances of any fall, any trauma or infection, etc. There are chances of vein abscess there, but it is less. Never say absolute. So what will happen during that time? Because during that time there is polycythemia causing the damage. So sug is blood supply to the brain. And there may be some clot formation also there. That can give rise to hemiplegia. Hemiplegia may occur after the age of 2 years also. But also another thing, the hypercyanotic spell is more common below the age of 2 years. Because after the age of 2 years, child is becoming adaptive. Child knows that by this time there will be increased discomfort, a child is lying down or squatting position. Because child can adapt itself, which is not possible below the age of 2 years or 1 year small child. Okay? Is there any question from this side? Now question from the middle. Question from the middle.
P2 টা কেন লেস করে?
হ্যাঁ?
P2 সাউন্ড।
P2 সাউন্ড মানে ক্লিনিক্যাল পিকচার বলছি, সে তো ক্লাসে বলবি ক্লিনিক্যাল ক্লাসে। ঠিক আছে, আমরা বলতে পারি কি P2 সাউন্ড in Fallot septology you see the pulmonary artery is narrow, so valve closure P2 closure is very poor closure sound of P2, and also the aorta is overriding the pulmonary artery. Aorta is overriding the pulmonary artery. Aorta is overriding the pulmonary artery. What is the relation between this picture is taken from the Nelson's textbook of pediatrics, but what is happening that actually this is not the exact position of the aorta and pulmonary artery. What is the exact position of the aorta? Normally pulmonary artery is in front of the aorta. In Tetralogy of Fallot aorta there is some rotation, and aorta is coming in front of the, to some extent in front of the pulmonary artery because of the overriding. So these pictures should come to some extent above the, close to the aorta or more to the right ventricle. And what is happening there? Aortic valve, as the aorta diameter is high, and aortic valve will close with more force, and that can give rise to loud second sound. So P2 is single and loud. Second sound is single and loud. This is that will be discussed in clinics, not in theory class. কি বলছো? থিওরিতে ক্লিনিক্স কি হবে না, এত কম সময় প্যাচে প্যাচে ক্লিনিক্স হচ্ছে, ক্লিনিক্স তো চলছে। We will discuss this today. আমাদের তো ক্লিনিক্স আছে, we will know the every second sound সম্বন্ধে আমরা ডিটেলস পড়াবো। তাহলে এনি কোশ্চেন এদিক হয়ে গেছে, এইদিকে কোশ্চেন, হ্যাঁ বুঝছো এতক্ষণ শুনে রাম সীতার পিসি হচ্ছে, হ্যাঁ আরে হাইপক্সিয়া হচ্ছে তো, এই হাইপক্সিয়া causes the increase in hypotension secretion, আর hypotension হলে বন্যার তো কি হবে, আর বেশি প্রোডাকশন বেশি, হ্যাঁ